I am going to give an update on some research that I did present, I think, five years ago here, and so tell you a little bit about what we found since then and where we're going with our work and how we can apply it in the real world to early diagnosis and early screening. Okay, so an outline of today's talk, we're going to begin with a discussion of early red flags for ASD that you can see in the first year or 2 years of life. Then I'm going to talk a little bit about how stable or reliable early diagnoses are, because people often wonder that, and if you make a diagnosis early, is it really a good diagnosis, and is it going to stick? I'm also going to talk about other challenges that we see in siblings of children with autism who don't develop autism themselves, but they actually do have some other developmental needs, and so we'll talk about those and how early we might be able to detect them. Then I'm going to talk about how we can apply this to screening in infancy and what methods and measures we can use, and then finally how to work with families if you're engaged in the processes of early screening or early diagnosis. So to begin, we'll set the stage really for why we want to do this, what the rationale is. The median age of diagnosis is still over age 4 in the most recent CDC publication that comes out every other year and gives prevalence statistics. It also lists the median age of diagnosis in the United States, and it really has not changed over the last 8 years. It's been roughly 52 months since, I think, 2008. However, there's lots and lots of data showing that parents first begin reporting to healthcare professionals about concerns at an average age of around 18 months. And in fact, depending on the study, between a third and half of those families actually report the concerns before the first birthday. So there's a really big gap between when the parents are telling us something's awry and potentially could make a diagnosis, or at least could begin screenings and maybe some preventative interventions, and then when we actually make a diagnosis at age 4. And we're really wasting time when the brain is most plastic and when early intervention could arguably have the greatest effect. So that's why we're doing this work. Now, until about 10 or 15 years ago, there really were not good methods for trying to understand what the earliest symptoms were. If we really want to move the age of diagnosis into infancy, we need to know what the symptoms are in infancy. I mean, maybe they're the same as when the child's 3, 4, 5, but maybe they're not. You have to be able to study that to know and to determine whether you need to have different criteria, for example, for infants than you have for older children. So the only methods that we could use until a little, maybe 15 years ago, were retrospective methods. So basically the child was already diagnosed, and then we would ask them to parents to try to recall what the child was like back when they were 6 months, 12 months, 18 months old. Anybody here who's a parent will know that that is a challenge for most parents to report those kinds of things with any degree of real accuracy in terms of timing. And even in general, they often have global recollections, like it seemed pretty normal, or I don't remember anything specific, or they remembered it was not normal. But in terms of like getting exact timing, very challenging. The other method that had been used was collecting videotapes that families were making just for their own personal purposes, and then in a research setting, analyzing those and having coders, we call them, who would look at these videos and be trained to detect particular behaviors and to reliably identify them. And they would go in and sort of count those behaviors in the video, and that way you could see, oh, do children with autism respond to their name less when they're 12 months of age or 9 months of age? And that is it's a very good method, but it has a couple of limitations. One of them is not everybody videotapes. Now they do, but in the old days they didn't. And so you might get just to buy a sample of video. And then secondly, it's extremely labor intensive, and there's really no way to adapt that for something that could be used in a clinic. More recently, in the last 2 decades, we've started doing these prospective studies. And a prospective study is one that starts with individuals prior to the age at which the diagnosis would be made, and then follows them and sees them directly all the way through the window of highest risk for the diagnosis, so that you can actually see when the diagnosis can be made, or what the risk signs are prior to the diagnosis. And then what we do is the child is longitudinally assessed at particular ages. Now, if you were just to do this out in the general population, you'd have to have 100 babies to follow, and only one would develop autism, luckily, but it makes it an inefficient research strategy because you're spending so much money and so much time and effort to follow these 100 infants, and only one ends up having autism. So what we do instead is we follow high-risk samples. And there are a lot of different types of high-risk sample. One might be infants who had been born prematurely, for example. But the kind of high-risk sample that many research studies have used is a high-risk sample because of genetic risk. And so that is that they already have an individual in the family, a child in the family diagnosed with autism, and now the mother's pregnant or has had a new baby. And there is a lot of research showing that genetic factors are highly influential as a risk factor for autism. We know that the rate of having a second child with autism, if you already have one, is about 20%. So that raises the risk about 20 times over the general population. So therefore, if we study 100 infant siblings of children with autism, we'll get 20 that will provide informative data for trying to determine what these earliest risk signs are. So at UC Davis, my colleagues and I have been studying, using this infant sibling design, cohorts of individuals since 2003. And we collaborated with UCLA on the first couple of studies that we did so that we could have a larger sample. So first, from 2003 to 2008, we saw 350 babies, and we studied the infants 5 different times, and at the 36-month visit, then we would do a very comprehensive workup for autism for everybody, whether they're in the high-risk group, the low-risk group, or whether they've had any concerns raised about their development in it before 36 months. I should also mention that if a child does show signs earlier, we do diagnose them earlier, but at 36 months, everybody gets a full workup, whether they've shown any signs or not. We did get funded a second time from 2008 to 2013. We saw 300 more children. This time we added a couple of assessment points. So we saw the babies at 9 months and at 15 months, because as you'll see soon, a lot was happening in that period that we were missing out on. So we wanted them to come in more often to check the child's development. Then we got funded again. We're in this phase right now. We had to drop back because they cut our budget back to 5 visits, but that's fine. And then we've also been funded a couple of times to follow the kids up when they're older. So our first sample, we've seen them twice, when they were 6 and then again when they're 9 to 12. I'm going to tell you about that later. And we've also followed some of the kids in our second phase when they are older. And now we just found out like a week ago that we got funded one more time, so we're going to follow them up to age 16 starting soon. All right, so the study has 3 goals that I'm going to talk about today. First, to figure out what those most earliest reliable markers are, then to determine their stability, and finally to look at the other problems in the siblings. And so let's start with the first one. So we have a really wide range of measures. I'm not going to go through all of these, but just to give you a little bit of an example of what we study, you can see that we look at some really obvious categories that would be relevant for diagnosing autism, like communication skills or social emotional skills or face processing, all things that we know are difficult for people with autism. But we also cast a broader net where we wanted to look at some things that might be a little different from or broader than, say, the diagnostic criteria for autism, because we just don't know what it's going to look like in infancy. And it's possible, for example, that there will be some sort of a precursor kind of behavior that we could pick up in infancy, and that the child has some impairments in that potentially over time would cascade into the full symptoms of autism. So we really wanted to look at a lot of different things. So for example, we also looked at motor behavior. We looked at how they processed figures and how they process objects, how they process even motion. Are they able to detect motion? How their eye movements are, and if they're smooth versus jerky, whether they could match speaking faces with speaking voices, so whether they could integrate audio and visual information. So we looked at a lot of different things. The first thing I'm going to show you is something that we did to look at face processing. So we had a video link between the mother who was in a different room, had a camera trained on her face, and her infant who was in the other room looking at a screen of her face. And they could communicate, quote unquote, live in real time. The reason we didn't have them next to each other together is because in the infant's room, the computer monitor that they were looking at has cameras embedded in the frame of it that are able to track where the baby's eyes are looking while the baby looks at the mother's face. That's what we were really interested in. So the mother's talking to the baby in real time. The baby can hear the mother and look at her face. And then we look and see where the baby looks. And specifically, we want to know, does the baby look at the mother's eyes, or does the baby look elsewhere? Maybe not even at the mom's face, period. The paradigm that we use is called the still face paradigm, and that's a developmental test that's been around for 60 years. And in that task, what happens is that a pair, mother and infant pair, are interacting and then as normal, and then a few minutes into it, the mother's given a signal to become still. And so she can look at the infant still, but doesn't respond in any way. So she's not being reciprocal the way a normal interaction would be. So the mother no longer responds to the baby's vocalizations, doesn't respond if the baby's smiling, and just sort of stares at the baby with a blank face. You'll see what it looks like in a minute. And what reliably happens during this, and this has been shown for years upon years, is that the babies stop looking, so their gaze decreases, and they stop vocalizing, and their positive affect, their smiling, goes down. And then the mother's given directions to start interacting again as she had before, so we call that the post-still face. And then what you see is all of those variables sort of go back up, and they start looking at the mom again, they start smiling at her, and they start vocalizing. So we were really interested in that pattern, and the reason why is right before this study started, there had been a really important paper that had come out from the Yale autism team, where they had adults with autism using the same kind of eye tracking technology, but instead of doing it in a live interaction like we did, they actually had them just watch a movie, but a very emotionally evocative movie, which is Who's Afraid of Virginia Woolf? And so this is a still out of their paper, and what they did is averaged across the plots of individuals with, or across the the data of the individuals with autism, and they plotted those in green, and the individuals of typical development, they plotted that in yellow, and you can see it over here too. And what they found was that the adults with autism looked mostly at mouths, and the typically developing adults looked mostly at eyes. And you could see that here in the still, but you can also see it very, very clearly where there's way more looking at mouths in the group with autism in green, and much, much less looking at eyes, okay? So we thought, wow, You know, we saw that in this little girl. I wonder how many other children are showing this. And so we created a variable that got at the amount of looking at eye, as we call it the eye ratio. And what you can see is that we had 10 children who mostly looked at mouths, like that video that I just showed you. Actually, I think we had 11, sorry. 11 children who mostly looked at mouths, so they're all the ones underneath this dotted line. And the other thing that was really exciting is that 10 of them, so almost all of them, were in the autism group or the high-risk group. Only one was in the typical group who looked at mouths very little. So we thought, oh, this is probably an early red flag for autism. But then we had to wait for 3 years till they grew up. We could tell who had autism and who didn't. And it turned out that in this is just a small sample that had been given this task, but it turned out in that small sample there were 4 children who developed autism. Actually, 2 were in the typical group, surprisingly. And it turned out that they all looked almost all at the eyes and didn't look at mouths a lot at all. And in fact, the child that is plotted, who I think is either this child or this child, because she had very little looking at eyes, turned out to be completely normal. And she was fine. And in fact, so did all the rest of the children in that low eye ratio cluster. So, well, was it related to anything else other than making us humble? And it turned out that it was. The children who looked at mouths predominantly, that group, ended up having higher expressive language. And that was whether it was measured directly when they came in and did testing with us, or whether we had families fill out a questionnaire about their child's vocabulary and in other ways. And actually, there's been lots of studies replicating this finding in general population samples where actually looking at mouths does predict language development. So that has now been replicated many times. At the time, we were really surprised. Now this is an overview slide that lists many of the measures that we give. It's not fully exhaustive, but most of them. And then plots across in the other columns when we first see group differences between babies that have autism outcomes and low-risk infants. And this slide we update all the time. I mean, the study's now we're in year 14 of this study. So every time, children are diagnosed, we're adding to the sample size is getting larger, we can sort of retest the effect over and over again. And so these are current and up to date. And you can see something really striking, I think, which is that there's not a single thing at 6 months, doesn't matter what the area is, object use, social, imitation, face, empathy, vocalization, all of that. It looks the same in the the babies who develop autism from those who are low risk and develop typically at 6 months. But second striking conclusion to us, we thought at least, is that by 12 months, everything is significantly different. Not just some things, not 1 or 2, but their development is declining in a lot of different areas, in a lot of different domains. And you can sort of see this in this graph right here. And the red are the individuals who have developed autism by 36 months, and blue are the low-risk typical controls. And so you could see, and this is supposed to say 6 months down here, and then it goes up to 36 months, and it's all those visits that we see them. What we do is we count the number of times that the infant looks at the examiner while they're in our sessions, and we just plot the number. It's a frequency. And what you could see is at 6 months, there's no differences. Even though the autism group's actually higher, they're not statistically different. So they basically have the same amount of eye contact at 6 months, but over time, it really declines so that they're almost never looking at the examiner by 18 months here and all the way through. So what we've shown in this particular paper here is that there's this decline over time in a whole variety of different different variables. I've just illustrated it here with eye gaze, but where they start essentially the same as the other babies, or all the babies look the same at 6 months, but over time, those with autism decline in their development. And we've shown this in a whole bunch of different ways. So the graph I just showed you was from a paper in 2010. This is a paper we're working on right now. So this is a paper that's a fully independent sample, doesn't have any of the same children in it. So these are the kids we've seen since 2010. And you can see that we have essentially the same findings. So here we have the individuals who develop autism in orange. And you can see again that they're declining from 6 months, their eye contact, which is about the same as the other groups, over time to 36 months. Same thing, decline in eye gaze. So that is a replication, brand new independent sample. That's with the examiner, but we also code it with the mother. And we only do it up to 12 months just because that's how far we gave this particular task. But you can see, again, same idea, declining trajectory over time, where they start off the same as the other groups at 6 months, but they show a decrease in their eye gaze to the mother. So this isn't just something they're doing with an examiner. We can also see it with the mother. You can also see it in responding to their name. So they start off the same as the other groups. By the way, the other groups that I have plotted, this is the rest of the high-risk group that doesn't develop autism. So compared to that group, the children low risk and the non-ASD high-risk group increase in their responding to name over time, but decrease in the autism group. And then in addition to there being all these behaviors that we can code in the session, which is also very labor intensive, we collect ratings that both the examiners and the parents give. Because what we'd really like to do is see if those same kinds of findings would be evident if we asked people to do ratings, which are obviously a lot easier to do than to count the exact numbers of eye contact in a session, right? And so we have the examiners do these ratings at the end of every visit, and you can see again pretty much exactly the same pattern here. The red is the group with autism and blue are the typicals, and the examiners just are rating how much eye contact they have, how many times they smile, how much they vocalize between 6 and 36 months. So that was a paper we published in 2010. This is a paper that we presented in 2014 at a conference. It's not published yet, but we're working on it. So this is an independent sample from the one I just showed you on the previous slide, but you can see the same thing. What we wanted to do here is plot all the individual trajectories. So this is all 20 children that developed autism in the second sample. We wanted to see if how many of them were showing that decline. Was it just 1 or 2, but maybe they were so striking it pulled the whole group down? Or was this something that at the individual level, lots of babies were showing? And so you can see that it is pretty, there is a large group of kids who start off with higher scores at 6 months and show these declines over time. That's from the examiner ratings. We also did parent ratings in the second phase of the study, and you can see that the parents are rating the babies very similarly too. So at 6 months, a lot of the parents are giving the babies higher scores, similar to the scores of the low-risk group, and then over time, every visit they come in, they're rating their baby lower and lower and lower. So even parents doing this prospectively are capturing this change in the baby, or this decline over time in their social engagement. Now at the end of the study, so at 36 months of age, we do an interview that's a really standard interview called the ADIR, used for diagnostic purposes, and it has a few questions where you ask the parent when they first became concerned about the baby's development. And then you ask them, did you ever worry that there was a period where your baby started to decline or to lose some skills that they had previously acquired? And it's just sort of a yes-no thing. And what happened is that of the 18 babies showing this sort of declining trajectory, Only 6 of those parents said that they had noticed the decline, even though these are their ratings right here. So they were the ones who were rating them with this decline, right, in red. But yet at the end, when they had to sort of conceptualize how their baby's onset was, or think about the pattern over time, not just today, that particular day they did the rating, they didn't see it as a decline. In fact, one of the ones who had the most striking decline here, this baby, the parent said he was always like this. Like, she didn't remember at all that he had been more typical, in fact, pretty indistinguishable from anybody else at 6 or 12 months of age. Some of the parents did, so about a third said, yeah, you know, we definitely saw that he or she had these big declines in behavior over time, but only about a third of them did. This is another way that we look at our data, and these are all the children diagnosed up to the time I made this slide 2 weeks ago, but yet we have actually diagnosed 2 more since then. So up till that point, we had diagnosed 48 children with ASD, and we plot them as green if they have all of their developmental scores in the average range, nothing is outside the average range, and the parent has not raised any concerns. We actually do a formal interview asking them if they have concerns, and the examiner did not have any concerns about the baby. They also fill out a form like, do you have any concerns about this baby? And so if all 3 of those were fine, we plot them in green. Yellow meant one of those or more were off, so either the parent or the examiner were concerned, or the scores were low, or maybe all 3, some combination, and then red is just when we formally diagnosed them. And so you could see it's very similar, but depicted in a different way, that there's this change over time where it was very, very hard to pick up all but 4 children here at 6 months of age, 4 out of 44 who were seen at 6 months. And everybody else looked very typical and how we would expect them at 6 months. You can see at 12 months, still about half of them seem to look fine. But the other half are all starting to show concerns, and you can see we've actually diagnosed 2 children at 12 months of age, including the one I showed on that video. We did diagnose him then. And this pattern of no differences at 6 months and then emerging differences by 12 months or later has now been replicated by a whole bunch of different groups. And so I've just put in some of those references here. These are all people at different sites doing the same type of work, but maybe using their own task and certainly their own sample and their own observers and all that. But this has now been a very well replicated finding that the babies initially seem fine and over time seem to change and autism emerges. This was a paper that actually got a lot of press recently from the Emory autism team, and they used an eye tracking task really similar to ours, but they started it at 2 months of age. That 2 is for 2 months of age, and you can see there the babies at 2, 3, 4, 5, and 6 months look pretty much like the typical babies, right, up to here. But right around 6 months, it starts declining. So this graph looks very, very similar to our graph, except we didn't have this part of the curve there because we didn't see our babies between 2 and 6 months. So it's been very, very well replicated. So the conclusion from this part of the talk, first of all, is that autism signs emerge over the first 2 years of life. Kanner had said in one of his earliest papers that autism was probably constitutional and present at birth, and that doesn't look like it's the case. At any rate, the behavioral manifestations of autism were the symptoms and signs of it. Most children who are developing ASD show this declining trajectory. So we used to think that this, we call it regressive onset, was not the norm. It was the exception, that only maybe a quarter or even a fifth of children showed this kind of a trajectory. But if we look at it prospectively, it actually looks like it's a lot larger, and that maybe regressive onset is more the norm and this early onset where you can see signs right away is more the exception. Now, what's really exciting is that parents can identify that decline. So if we were able to have parents fill out some forms like this at every, say, well-child visit, one could potentially plot those just the same way we plot, say, head circumference. And if a child was starting to go down and not staying on the same percentile they had been on, it might give us some hint that autism is starting. So it was very exciting that we found that the parents' prospective ratings showed the same declining pattern. Some of the parents are able to report about a regression, but it's probably just the most extreme ones and probably just the tip of the iceberg. So it doesn't mean that if we ask a parent about whether their child lost skills, that their answer is wrong. It probably is most likely right if they say yes. But if they say no, it doesn't necessarily mean that the child did not have a regression. All right. So then the second objective of the study is trying to determine how stable these early diagnoses are and if we can really rely on them if we're able to make one this early. So I'm not going to go through all of this because it's really busy here, but just let me orient you to what this slide is showing. It's basically showing all the children with ASD at the time that we published this paper who developed ASD, and what happened to them between 18, 24, and 36 months. So we have a group that was diagnosed with ASD at 18 months, and you can see that a majority of them continued on to have it at 36 months. But a few of them we didn't think had ASD at 24 months, and some we continued to not think they did. Others we reversed our opinion. And then we have a few kids over here that we thought didn't have ASD at 18 months, but then by 24 months we thought they did. Here's another group, no ASD at 18 and 24 months, but then by 36 months we thought that they did. And you can see it's a really large, these are large groups. So there's two statistics that are of most interest when you're looking at stability. One is sensitivity, and that is how well your instrument picked up the kids who actually do have autism. And you can see that at 18 months, the sensitivity is really low. It only picked up 37% of the kids who have autism, about a third, who are ultimately going to have autism at the 36-month visit. At 24 months, it was better, but it still picked up only a little bit over half of the kids who are going to have autism at 24 months. Specificity, well, I guess I'll skip over specificity, was good. But the other one that's of most interest for screening is what we call positive predictive value, or that's also stability. So what it means is if you got a diagnosis at one of the earlier ages, how likely are you to keep it? Or is it going to be stable over time? And you can see that at 18 months, our stability, or PPV, is really good. It's 93%. So most of the kids that we picked up at 18 months, we continued to think had autism at 36 months. At 24 months, it's actually a little bit lower. It's 82%, but that's still actually very good. The stability of autism in general at age 3, 4, and 5 is around 80%. So that's how likely it is that a child diagnosed a little bit later will keep their diagnosis. Some of that's probably due to inaccurate diagnoses. But at any rate, so 82% is actually very good. But the interesting thing is that it's even higher at 18 months. And I think the reason there is because we wouldn't have diagnosed it at 18 months unless we were really, really, really sure, because that was such a young age. And so those children just showed very clear signs and got diagnosed, and then were very likely to keep their diagnosis over time. So conclusions for this, first of all, is the diagnosis before 36 months is very stable. Over 90% retain the diagnosis. And this implies a couple of things. First of all, if a child gets an early diagnosis, you should just start intervention right away. There is no need to just wait and see or just be sure or whatnot. And then secondly, and this is something that I used to routinely do, but I do not do it anymore, we used to say that the diagnosis should get confirmed at a later age. And that is both hard on the service delivery system, and it leaves the families in a lot of limbo about, like, should I pursue intervention yet? Does he really have autism? There really is not any need to do that unless the child's phenotype suggests that the diagnosis was wrong, and that could happen, of course, at any age. And so early diagnosis is good diagnosis still. There were very, very few false positives. So there were very few children that we thought had autism at an early age, and then we retracted the diagnosis later. However, there were a lot of what we would call false negatives. In other words, children who at earlier ages we said they don't have autism, and then later they did. And one could say that was due to errors or inaccuracies in the diagnosis. That's often what we mean when we say false negatives. But we think, not just being defensive about our practices, but we think it's not that. It's that the autism signs are emerging over time and that they weren't there to pick up earlier to get the earlier diagnosis, if you think back on all those graphs I showed you earlier. So whichever it is important to realize that any child who passes a screening early on isn't necessarily out of the woods, and that you need to rescreen and keep your eye on children, particularly high-risk children, over time. But by 36 months, it will be pretty stable. All right. The third goal of this study is to think about what other developmental problems can occur in the infant siblings, those who don't develop autism. So we published a paper in 2014 where we looked at the 36-month outcomes of all the children in these two groups. And I already have told you a lot about the group that develops autism here, which was about 17% of our high-risk group. But then we had a group, 28%, so over a quarter of the siblings, who had a variety of other kinds of problems. Only a few had sort of global developmental delay, maybe like intellectual disability. A scattering, we were a little bit worried might have ADHD. They had very, very hyperactive, impulsive behavior beyond what you'd expect for a 36-month-old. A small group had speech and language delays, but not autism. And then a slightly larger group, so about a sixth of the sample, had something we call the broader autism phenotype, which is essentially a way to describe subclinical social communication problems. So children who maybe have a little bit less good eye contact, are a little bit less engaged with people, are a little bit, they might be delayed in pointing or in other aspects of nonverbal communication, but they don't meet criteria for autism, they don't seem like they have autism, it's subclinical. And then you can see in the low-risk group, there's fewer of those classifications, about 9%. We saw the kids again at 6 to 7. 15% had autism, and I think this says 32% were in the non-typical group. And then when we break down what the non-typical subclassifications were, you can see that this rate of the subclinical social difficulties was about the same as it had been at age 3. Now we could actually do real diagnoses of ADHD, not just concerns about it, and actually 10% of the siblings met criteria for ADHD, a little bit over, and some had speech and language disorders, but overall those had gotten better, so there were fewer with those. A few had been diagnosed with learning disabilities, most likely dyslexia, or most commonly dyslexia, and just a very small handful had anxiety or mood problems. And in the low-risk group, 13% of kids versus 32% came up with those kinds of diagnoses. Then we saw some of the sample again. This is just a small version or small group of kids that have gotten to be this old yet, but this paper just got accepted for publication. And we looked again at ADHD, and this time we had a much, much higher rate of ADHD than we had when they were 6 to 7. So now it's close to 40% of the siblings of the kids with autism are meeting full DSM-5 criteria for ADHD, whereas very few of the low-risk children are. And that was whether we used DSM-5, or here all we did was just quantify the level of symptoms. We have 3 or 4 different checklists for ADHD that parents fill out, and I can't recall which one this is based on, but you can see whether we were asking parents to rate the child's inattention, how hyperactive impulsive they were, or just their total score, that the high-risk group in general had much higher levels of all of these behaviors. So it tells us that probably these same genes that put children at risk for ASD look like they put them at risk for ADHD too. So some of the clinical implications of this work, just overall, these infant sibling studies that we've been engaged in for the last 14 years, there are very few markers of ASD at 6 months or earlier. We are very much still interested in seeing if we can find some of those, and what we would really, really like is to be able to identify risk before the behavioral signs even start. And we're engaged in work to try to do that, but so far hasn't happened. We see these declining developmental trajectories across domains. We've replicated it multiple times, and other groups have replicated it multiple times. Early diagnosis is very stable, but you do need to screen a lot. And in fact, the recommendations of the American Academy of Pediatrics to screen at 18 and 24 months are probably just not sufficient. You have to screen again at 36 months. And then finally, having a family history of ASD really is a risk factor for these later born siblings, and one that should definitely be noted by individuals working or providing medical care to these infants. So you can see here, though, that what I've done in this slide is try to do an analogy between the kinds of things that would be recommended if you had a family history of cardiovascular disease. You go to your doctor, they want to be sure you're not going to have a heart attack or a stroke. They do screening, they ask you about your family history, they measure your cholesterol, they try to get you to stop smoking if you are, or to exercise more, change your diet, that kind of thing. Now, autism is very similar to this in that if we know that we have family history risk over here, older sibling has autism, this child is 20 times more likely than the general population infant to develop autism. And so you'd think we would be doing some of these exact same things. Number one, screening for the family history, but then instead of at a well-child checkup, spending a lot of time just on the child's physical well-being, checking in about how's their eye contact, how interested in other people are they, do you have any concerns about their responding to their name, those kinds of things. And that really isn't happening, much less any sort of preventative interventions being offered to children in this high-risk group. So the American Academy of Pediatrics published guidelines in 2007, recommendations that is, where they said that primary care providers should be aware of early signs of autism, perform surveillance at every visit, meaning that they should elicit parent concerns, ask about if they have any concerns in any of these areas, and then, of course, regardless of what the parents said, at 18 and 24 months that they should do a screening of all children. And I think that these are not fully being implemented yet all over in all pediatric practices, but as I've said, some of the data I presented here means they probably didn't even go far enough yet, and that there's going to be needing to be a more extended period for screening. I have this here so it's in your handouts, because a lot of times family members or professionals will say, well, I don't know what they should be doing at these ages, so how will I know if they're not doing it, or if any of these red flags are present. So these are for you to have with you, but some of the things that we would expect at different ages for infants to be able to do, and if they're not, would warrant some concern or a referral potentially. So babies by 1 month of age absolutely understand that the eyes are the central part of the face and they're looking in people's eyes. By 1 to 2 months, they're smiling at other people reciprocally and for social purposes. By 3 months, they have a bunch of vocalizations. Those vocalizations can involve even turn-taking, where the caregiver and the child go back and forth in little bouts. By 6 to 9 months, they should be adding some consonants into their vocalization, so they're just starting to have some babbling with consonants like ba, 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 ba. They should start responding to their name between 6 and 9 months. Between 9 and 15 months, they should be using gestures and pointing, and then a little bit older, 12 to 15 months, should be starting to imitate really reliably. So across lots of different studies, is not just our study, some of the things that we've seen as red flags for autism and that some of the empirical studies have shown distinguish infants with autism from typical infants are things like looking at faces starting to decline between 6 and 9 months, or vocalizing in sort of cooing patterns or smiling at other people. By 9 to 12 months, there's been multiple studies documenting that babies developing autism aren't responding to their name the way they should be. They're not babbling as much. They're not interested in playing face-to-face social games like peekaboo, etc. So this is at the group level. There will be many children who won't show the signs at any of these particular ages, but these are the ages where we have documented them at the average level. So what are you supposed to do then if you're in practice or you're following infants? There are some screening tools that are available. One is the Infant Toddler Checklist, and that was published by Amy Weatherby and Barry Prezant. It's available for free, and I've put the hyperlink in your handouts, so you can go straight there on the internet, and it has scoring, whatever, directions, and norms are available there, and all that. So that's a really helpful measure, and it goes all the way down to 6 months of age. And then there's something called the Modified Checklist for Autism in Toddlers, or the MCHAT. It starts a little bit older at age 16 months, but goes up higher. And again, available free on the internet. All right, so now I'm going to just finish up by talking about a screening project that Elizabeth, when she introduced me, referred to in brief. And this is that we're trying to develop a measure that uses video rather than uses just paper and pencil testing to try to screen for autism. And one of the reasons is because people often learn from video much, much better than they do from just reading simple directions. A lot of times families say, well, I'm not really sure what you mean when we interview them, when we ask if they point or if they imitate or do other things. And this way they can actually see video examples of it and understand exactly what we're asking them to rate. So the way this measure first got developed is we had John Constantino, who's pictured here, giving a talk at the Mind Institute. And he was talking about how a measure that he developed called the SRS, you might have used it, the Social Responsiveness Scale, how they were trying to improve it by adding a video to it, and that before the parents would fill out the SRS, they would watch this 2-minute video. It was just of one child, and then say, and point out things like, this is a child who's very socially competent, and look how she can do this, this, and this, and sort of would calibrate the parents in a way so that they would then be able to do more valid ratings, maybe. And so he was sitting there talking about this, and I thought, that is a really cool idea, but we don't have just, one video to show one socially competent child. We have like literally hundreds of well, actually, we have like over 10,000 videos. We pretty much videotape every single thing from the second the child walks into the room till they leave. 2.5 to 3 hour session, they come 7 times, and then you can clip those up into little small clips. And so we have gazillions amounts of video, where we thought, oh, here it is, 300,000 minutes of high-quality video footage of infants. And so we thought, wow, we could put together a really cool measure with not just one infant, but in fact calibrate across, sort of low competence to high competence in particular behaviors, where they could see a real range and maybe rate, my child's more like this child or more like that child. So we got money from both Autism Speaks and NIH to develop this measure. And we're calling it the VIRSA, the Video Referenced Infant Rating System for Autism. And it is a video-based measure for 6, 9, 12, and 18-month-olds, and it measures social communication behavior and somewhat repetitive behavior. It doesn't actually perform that well on the repetitive behaviors, but at any rate, we're still in the development phase. And we are testing to see if it works before we unleash it upon the public, to see how reliable it is. Like if a parent rates it one day and then does it again a week later, do you get a similar score? We're looking to see if a parent rates it and an examiner rates it, do they come up with similar scores on it? And then we're looking to see whether the scores on this measure converge with other screening measures, like how correlated are they with the infant-toddler checklist and with the MCHAT. And then finally, the most important is we're looking to see if it predicts who has autism. So the parents fill this thing out, then we gotta wait till the kids get to 3, and we see how many of them have developed autism, and we can look and see if their scores on this measure were lower earlier on. So would this be predictive? The way that we constructed it is that families will watch a pair of videos, and they're paired to contrast particular behaviors. Each video is 20 seconds long, and it shows babies playing with their parents, and the clips give a range of sociability. So they usually start out with a child sort of high social or somewhat high social, somewhat low social to contrast. So as of now, this is how many of these we've collected, and you can see quite a bit. We have the parent do it right before they come in for the visit, but so that anything they see or we tell them in the visit doesn't contaminate their ratings. And then we have them do it a week later. And then we also have the examiner do it right after the visit, so we can look at how correlated they are. So this is the parent ratings, and what you can see here is the group with ASD, and there's not very many of them, only 12 have developed autism in this group that we're, now tracking. But you could see that their scores at 6 months start off really pretty similar to the typical group scores, which are these dotted blue line there at 6 months. And then over time, they decline, similar pattern as all our other measures. And by 18 months, that is significantly different. So the typical kids, their parents basically rate them the same over time. This group, the parents give them lower ratings over time. Now this is an interesting group, the other dotted group, and this is what we call the atypical group, for lack of a better name for it. But what that is infants that, remember when I showed you that green, yellow, red slide? Those are the infants in the yellow group. So we didn't diagnose them yet, but we have concerns about them, the parents do, or their scores are low in some way. So those are the babies that we're tracking. Now some of those kids, once they get to 36 months, are gonna join this group, right? Because some of them have autism and haven't been diagnosed yet. But some of them won't. Some of them are gonna have language delay, some of the other things that we documented, that broader phenotype or intellectual disability or whatever. So this group, we just don't really know what to make of yet, and we just have to wait over time till the grant's done. Everybody gets to 36 months, and then at that point, we can see what their differences are. But it is exciting if you just concentrate on these two to see that the parent VIRSA ratings by 18 months are able to pick up which infants have autism. And that's earlier than we normally would make a diagnosis for some of them. Now it turns out the examiners pick stuff up even earlier. So this is the examiner VIRSA ratings, and here we have the children who are typical in blue and the children with autism plotted in red. And you can see that by actually their 9-month ratings, the examiner's scores are significantly lower for the babies who are going to end up getting diagnosed with autism when they're 3. And then they don't differ until 18 months, again, from that atypical group. But we just don't really know what that atypical group is yet. So that, we got to wait till the study's over. These are preliminary results. But still, exciting. And it parallels the earlier slide that I showed you where we had parents do ratings not using video. So a couple of take-home points that we replicated this decline over time. One thing that's exciting is that by 9 months, the screening instrument can pick up the children who have these delays, whether it's autism or whether it's the atypical group, either one, they both have delays. But by 18 months, it can tell which ones actually have autism. And we hope that ultimately this would be something that could be, say, disseminated on the internet and would be very helpful for families if they were doing, say, searches like, how do I know if my child has autism? And instead of just pulling up a paper and pencil measure, they would actually be able to take this, look at the videos, and see whether potentially their child is at risk and they should try hard to get appointments for diagnosis. So just to wrap up then, I've described a number of ways in which the early diagnostic process involves some uncertainty. So we have that atypical group, right, who we don't know what's going on with them, or that group, that yellow group, where they're developing some symptoms, but yet they don't have the full diagnosis yet. And one slide I didn't show you, but as an important piece of information, is other children get that sort of yellow or that atypical designation who don't go on to have autism. Some of them go on to have other things, and a few of them actually go on and are typical. So there is a period in time where the symptoms are emergent or emerging, and we don't know what's going to happen to those children. How do we talk to families about that? I mean, that just seems like a recipe for absolutely raising anxiety when we don't know what's happening yet. And so we really do try to have a balance between not changing the relationship of the child and the parent by telling them something very alarming that we don't really know yet for sure, but keeping the family deeply invested in monitoring and tracking with us to try to figure out as early as possible what's going on with their child. So first of all, and I'm sure everybody strives for this anyway, but our bottom line really is just honesty. I mean, we talk to them about the limits of what we can say today and what we know for sure, but if we've seen something that we are a little concerned about, we also do tell them. We, by the way, let them know this day one of the study in the informed consent form and say, we will be providing feedback to you about such and such. So they're well aware that that's the purpose and, in fact, one of the benefits of being in the study. So we do openly communicate with families. We tell them we've seen children like this who go on to have autism, and we've seen children like this who go on to be fine or to have something a little less serious, like simply a speech delay. So we really just partner with the families, and then of course we offer to see the child at smaller intervals and to try to pick up as early as possible, if it is autism, to get them a diagnosis. We do talk to parents about sort of how they feel about a false positive, you know, sort of jumping the gun and diagnosing autism and it isn't, versus missing something. And families really do vary there. There are a lot of families who will be like, we'll just wait until you're sure. And other families are like, we want a diagnosis today. So it is absolutely different across families, and you can talk to them about these kinds of things pretty well. Then finally, regardless of what the ultimate diagnosis is going to be, our testing tells us sort of how they are developing and what behaviors are atypical at that time, and we can give parenting strategies and advice for how to deal with those, even if we don't have a diagnostic label. So I'm just going to finish. This is my last slide by saying that these are some of the things we do provide to our families when they come in. And some of these are really wonderful to provide even before you know the outcome of the child and whether they do have autism or not. So I'll start off with pointing out this because it's more general. You can see in this title, it doesn't say anything about autism. It's called an activity kit for babies and toddlers at risk, how to use routines to build social and communication skills. So this is a perfect thing to hand a parent or to give them this book title for them to go buy if you're not quite sure what's going on yet. And it's filled with really great activities to try to pull the child's focus to your face, to make eye contact, to build their vocalizations, and lots of things like that. Now, if you're pretty sure the child does have autism, then this is a wonderful resource written by Sally Rogers, my colleague at the Mind Institute, and Jerry Dawson and other colleagues, and it's called An Early Start for Your Child with Autism. It's a parent guidebook, just like the Fine book is. That is really accessible to families. It has things that they can copy and paste on their refrigerator to remind them of things that they should be doing or could be doing in just the ordinary, feeding, bathing routines of everyday life to help draw out their child and improve their social and communication skills. And then another book that I like that is not interventional, but it's really just more about what is early autism, is this book called Does My Child Have Autism? And that's something we also give out to families when they're sort of in that concern zone, but we don't really know what's going on. And we say to the parent, read about this, and when you come back, let us know what you think, after you've read this, and what you've seen or hasn't seen, what fits, what doesn't fit. And then finally, just to remind people, which you probably know, that the Autism Speaks website has a really wonderful resource called the First 100 Days Kit. It's free, downloadable as a PDF, and it basically goes through the things that you should be doing in the first 100 days after getting a diagnosis to get your child set up for services. So the question is, how well do we pick up the kids who end up having Asperger's syndrome, or in DSM-5 we don't have that, but maybe have much milder versions of autism spectrum disorder, and are we able to pick them up in infancy? That is a great question, and it's mixed. So we have several children who have that sort of Asperger-like profile, and we've now seen at 6 and 9 years of age who we did pick up in infancy. One of them we picked up, I think, at 15 months and one at 18 months. But we've also had two, it's not a lot, but 2 children who came in at 6 or 7, I forget which, but at any rate, and they definitely had Asperger's syndrome, and we did not identify them. And now we have all that video on them, and we've gone back and looked at that and sort of done an autopsy of our methods and tried to figure out, could we have picked him up, or why didn't we pick him up? What was going on? But both of those little boys' ADOSs looked so normal. So it's a bit of a conundrum. The kinds of things that the ADOS identified did not pick up those children, but it picked up some other ones. So I think it's variable, that there are some children who really might not become as clearly symptomatically obvious until their language is a lot better developed and they can start talking about special interests, or they're so conversational that you can then really see the impairments in their back and forth, or you can really hear their intonational voice qualities that are off. Those kinds of things all seemed really normal at 3, but they all have sort of low standards because they're still developing at age 3. So quick answer is sometimes we could pick it up that early, but not always.
One question is, in the atypical group, I was interested to see that you didn't have anyone with OCD, none of the kids with OCD. And so I'm wondering, when we see these kids that are just very systematizing, organizing, the ones that go into the kitchen and make sure all the drawers are closed, that kind of thing, do you think that is, at an early age, do you think that might be sort of a super red flag, or an extra thing that should make us think, no, this isn't going to be OCD, this is going to be, this fits with an autism spectrum disorder?
So that's an interesting question. So far, we haven't actually identified anybody with OCD at all. I mean, like out of hundreds of kids. We are now, like I said, just found out we're funded to see them up to 16, and it is possible that some of them between 9 and 16 will have developed it. And then, in fact, what this new grant is about, we're going to be doing like full DSM-5 diagnoses of just like all the common stuff. So, you know, depressive disorders, mania, psychosis, all the anxiety disorders, including OCD, which isn't in the anxiety disorders anymore, but all of them. And then we have video of these babies from 6 months on, and we could go back and look and see what the predictors were of OCD, of ADHD, of anxiety disorder, you know, generalized anxiety disorder. So that's what we'll do next. It is at least worth saying that it doesn't look like that's a really common, at least up to age 9, outcome in the siblings of kids with autism like ADHD is, which does have an earlier age of onset, but in any rate, so we'll see. But so far we haven't. So,
I was just wondering if you collected any data on parents and possible risk factors, like maybe parents with depression or personality issues like introversion versus extroversion factors.
yes, thank you. So we do collect a little bit of information about parents. First, they do self-report. We don't do like a full diagnostic workup, but they do self-report if they've had previous, you know, depression or anxiety disorders or other things like that, learning disabilities, et cetera. And then also we have them complete the social responsiveness scale, which you can give for kids with autism, but actually goes all the way up for adults, and it can be used, in fact, it was developed for use not just for autism, but in the general population. So it gives like a quantitative measure of social communication skills, and therefore you could see potentially if a father or a mother had somewhat lower social communication skills, would that mean that their infant was at higher risk? And it turns out we have looked at that once. We did have adequate statistical power, and we didn't find anything. We should look at it again because our sample's like double the size now. But the first time that we took a sort of a quick pass through that, we didn't find out that those kind of parent variables were predictive. We haven't looked yet at depression or anxiety, so we'll do that too.
My question is for the high-risk siblings with the ADHD. My son is going to be 5 in a few months and wanted to know if the Mind is offering testing for ADHD since he's at high risk, or if we should ask, say, Kaiser or whoever our medical is, can they test that early for ADHD?
That's a wonderful question. I'm really glad you asked that because one of our other things that we're doing in this study, I didn't even talk about it, is we have another risk group that has older sibs with ADHD. And we're studying them from birth on as well, trying to figure out how early can you diagnose ADHD. This is something that a really talented postdoc in my lab, Megan Miller, is spearheading, and she was an ADHD expert before she came to my lab. And so the average age of diagnosis for ADHD, unlike for autism, it's 7, age 7. And so the question is, are the signs there earlier, and can you pick it up earlier, and is it reliable and stable diagnosis earlier? So we're working on that. Now, your question is, if you go to a community provider, would they be willing, I guess, to take a look at that? Are there measures that would be relevant, et cetera? And the answer is yes. I mean, if the provider is trained in ADHD diagnosis and the child shows a pretty clear picture, some children actually get diagnosed at age 3. So it is possible to do. I think it's partially whether a child does get diagnosed or not, a function of the expertise of the provider and of how clearly the child's showing the symptoms. If they just have a milder case, probably not. If they have a pretty extreme case, yeah, they probably could be. So you could probably talk to your insurance and find out if there are people in your network who would have that expertise. There is an ADHD clinic also at the Mind, but you know, you can maybe start with your own health network and see what's available. Did you want to add to that? Or no, you have a question. Okay, it was a pediatrician. I thought you were going to help me out there.
Oh, hi. Along with what the lady was just talking about, as far as for parent support, we have some parents from our preschool agency that are now going through their neurologist, and they come back the same day with a diagnosis for autism from a brain scan. So we're trying to encourage parents or is there something that they need alongside with that brain result scan that they had just received from a neurologist, or is that suffice enough for the school district? Or
so that's a very interesting question. Of course, the hope is that we could come up with some sort of concrete kind of biomarker or biological test that could diagnose autism where you didn't have to have some of the sort of subjectivity of a behavioral diagnosis. And so a lot of people are looking at that. We actually did a study. One of our cohorts also got an MRI, one of those three, the middle one, and then we followed them out to 36 months to see if there were any really reliable markers for who was going to develop autism. And it's a long story, but we did find something interesting. It's published, but it had a pretty high false positive rate. So in other words, most of the kids who had autism showed this particular sign on the brain scan, but so did a whole bunch of other kids, including some in the low-risk group who were completely normal. So our particular study did not show that you can diagnose autism by MRI. And I'll just go out on a limb and say I don't think that there are publications that do show that. I am not familiar with the practice in this region that's doing that, but I would approach it with some skepticism because I know the literature pretty well, and there are not any ways to make a diagnosis based only on a brain scan that I am aware of. Now, potentially there might be particular findings on a brain scan that, along with a pattern of behavior, helped a neurologist feel more comfortable giving an early diagnosis. I would have to know more about it. But at this point, the state of the science and of clinical practice is that you can't diagnose autism just with a brain scan. The other thing I would say, by the way, is that autism is the most reliable diagnosis in the DSM, and it has been for years and years. So although people do a lot of, there's a lot of concern about making a purely behavioral diagnosis without a biological confirmatory test, in fact, it's 80% of the time the diagnosis stays and is proven reliable over time. So it really, at this point, even though I know a lot of times families wish you could just take some blood or something and figure out if it's autism for sure, usually the diagnosis that you get is very, very accurate, if that's worth saying.
The UC Davis Mind Institute was created in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other brain disorders are helping children achieve their fullest potential. Please visit our website to find out more about current studies, upcoming events, and how you can help make a difference.